Hello everyone, am I audible and visible? Let me know, then we'll start. Am I audible and visible? Okay, fine. Hello everyone, welcome to Unacademy Future Doctors. I'm myself Dr. Dipti. I'm MD PhD Physiology. I'm Associate Professor and educating MBBS nursing, physiotherapy, dental, homeopathy and MD students. And I have more than 17 years of teaching experience. Now, let me explain in brief about our subscription. We have two kinds of subscriptions. Number one, that is plus subscription, in which you can access both live as well as recorded classes. You can study on the device of your choice. You can learn from India's top educators for your medical exams. You can access fossa versus notch difference. Priyanshu, hello. You are in physiology class. Let me explain. Huh? You are asking anatomy question. Okay. So learn from India's top educators for your medical exams. You can access QuestionBank, which is having more than 25,000 questions. You can compete in live tests and quizzes. And with 12 months and above subscription, you are provided printed notes too. Now, second is our iconic subscription. Here, your access to the best from two of the best. And which are these two? One, that is Unacademy and Prep Ladder with Unacademy. Now, features are, I have already discussed all. And second, that is Unacademy and Prep Ladder with Prep Ladder. And the features are, you can have clinical and integrated essentials. You can have video lectures from the Dream Team, QuestionBank 3 with active guidance, system tags and more. Rapid revision and snapshots and treasures and 2021 Dream Notes. Also, we have added certain features in our special class. One, that is we made the class interactive. You have a facility to attend the class, as well as you can fossa versus notch. Priyanshu, I will tell you tomorrow. Let me go through properly, as I know that fossa, that is a little bit deep notch, you can say. Notch is a little bit shallow as compared to fossa. Getting me? So as per my knowledge of anatomy, I can say, but if you give me time, I'll search and I'll let you know tomorrow properly. Is it fine, Priyanshu? I'll definitely tell you properly fossa and notch. Okay? So we have also added special class feature. We have made the class interactive. Also, you have a facility of raise a hand. You can poll for the learners. You can never miss a class. You can get lecture notes and you can attend your class anywhere and at any time. Okay. We also have upgraded and highly effective question bank, which is having more than 25 high yield questions, which are based on the latest exam pattern with with detailed explanation too. Okay. These are our NEET PG 2021 toppers. Also, we have started Focus FMG 2022 comprehensive batch from 15th December 2021. That is for 6 months. And target NEET PG 2022 test and discussion batch, that is also from 15 December, and that is for 3 months. Now, we have one surprise for you, that we have our NEET PG Mega Compact, that is for 60 minutes, and that is for 45 questions. You have to answer 45 questions, and you can be rewarded from a pool of more than 10 lakh rupees. Okay. Now, so here, as well as top rankers, they can get a chance to win 100% scholarship. We have questions from medicine, dermatology, anesthesia, psychiatry, and radiology. And question and video solutions, also curated by top educators, will be given to you. And note down the date, that is January 23rd. Okay, that is at 11 a.m. Okay, you can enroll now. Enrollment is free. You can use my code DIPTI10 to get free enrollment. You can unlock free test. Another is, also we have other test having 30 questions. Subjects are ENT, ophthalmology and pathology. Timings are on 17th January 2022, 12:30 p.m. 22nd January 2022, 12:30 p.m. and 28th January 2022 at 12:30 p.m. Okay. Scholarship details are: rank 1 get 1 year plus subscription plus 5,000 Amazon vouchers. Rank 2 6 months plus subscription plus 3,000 Amazon vouchers, and rank 3 3 months plus subscription plus 2,000 Amazon vouchers. Okay. You can subscribe also from your mobile either for plus or iconic subscription. You can use my code DIPTI10 and you can get 10% discount on each and every subscription. Okay. Now let us start with our today's topic. Today we will discuss our learning objectives are: one, we will discuss about one of the clinical topic, that is electromyography, electrical recording of muscle performance. And we will discuss one of the other important clinical topic, that is disorders of muscle. Okay, so starting with first, electromyography. What is electromyography? This electromyography, it is the technique of recording. You can also write down along with me: technique of recording the electrical activity. The name itself suggests electrical activity of motor nerve which supplies muscle and muscle. Okay, so this is electromyography. Okay, now, and the instrument used, that is known as electromyograph. Instrument used. Okay, instrument is electromyograph. Okay, now next, EMG reading. Which type of readings you get? At rest, you have complete electrical silence. No waves, no spontaneous activity is recorded. No spontaneous activity. Okay, that is recorded at rest. Except there is insertion activity. Insertion means when we are inserting needle. Okay, because for electromyograph recording we have to insert needle, so insertion activity is found. So at the time of insertion, you can see here, as I have shown you, this is, you can see electromyography. This is one of the important clinical procedure. Needle is inserted here. Okay, so at the time of insertion of needle, you can have this activity in the muscle, although muscle is at rest. Okay, and there is action potential, that is insertion activity. Action potential is recorded. Okay, and but this potential is of short duration and amplitude is also small. Okay, amplitude is also less or small. Okay, so this is your insertion activity which is found. Now next is, in some of the disease condition, this insertion activity is prolonged. It is prolonged in which disease condition? Like the muscle is denervated. We will discuss what happens in denervated muscle. There is denervation hypersensitivity. Muscle gets hypersensitivity, denervation hypersensitivity. Okay, as well as another thing, this insertion activity is absent when muscle tissue is not viable. This is absent. Okay, when it is absent, viable tissue is not there, muscles are not viable. Okay, so this is one activity which we found. Second is end plate noise. What is end plate noise? After we complete insertion activity, there is no other spontaneous activity is recorded. Okay, but for monophasic negative action potential, that is recorded at the end plate of the this muscle. You have end plate, at the end plate region slightly activity is recorded, that is end plate noise. Okay, now voluntary activity during muscle contraction. So when muscle was at rest, there is no activity, you can see normal. But when, you can see here, but when muscle is contracting, you will found certain activity. Okay, so when minimum voluntary contractions are there, okay, what you found is you will be having either one single or one or two motor units, because only one or two motor units are recruited. So activity found in one or two small motor units, okay, and it gives small potentials here, okay. But as increase in the voluntary contraction, when voluntary contractions they increase, what happens? You can see this recording also increases. Why? As we have discussed, there is recruitment of motor units. More and more motor units are recruited and you will get higher activity, okay. Now, and during maximum contraction, you can see here the activity reaches maximum here, okay, and this is known as MUP, motor unit potentials, okay. So this is normal EMG recording which we have discussed. Now next is abnormal activity. Sometimes there is spontaneous activities present at rest also. Muscle is not contracting, but some activity is present. That is, one is fasciculation potentials. I don't have the diagram of that. It looks like your motor unit potentials, okay? And it represent involuntary. Here there is involuntary contraction of the muscle fiber of single motor unit. One motor unit, suppose issue, hello, welcome to my class. Sorry, one motor unit, when it is stimulated, there is fasciculation, motor unit potential. Second is fibrillation potential. Here we have short duration, and you can see here low amplitude potentials are present. These are fibrillation potentials, okay, in absence of muscle activity, okay. Now, so this is we have discussed about electromyogram, maybe asked as a short question. Next we will discuss that is myopathy, disorders of skeletal muscle. This also may be asked as a short note, or individually different myopathies may be asked. Sorry. So what is myopathy? Myopathy is your neuromuscular disease in which there is dysfunction of either muscle fiber that leads to muscle weakness, okay. Here very important thing is nerve is not involved. If nerve is involved, that is known as neuropathy. So what is myopathy? That is neuromuscular disease in which muscle fiber dysfunction, and that results in muscle weakness, okay. Now some of the common diseases of muscle, skeletal muscle, we will discuss. That is, one is muscular dystrophy. This may be asked as a short question. Second is disease involving muscle tone. Either muscle tone increases or decreases. Third, fibrillation and denervation hypersensitivity we will discuss. Fourth, Myasthenia Gravis we have already discussed. Lambert Eaton syndrome and Macarthurs disease. So these three are more important. So many times question was asked. Number one, this one is important, muscle dystrophy. Second one, Myasthenia Gravis and Lambert Eaton syndrome and Macarthurs disease. Okay, maybe asked as an individual short note on each of this. Okay, now starting with first, muscular dystrophy. What is this muscular dystrophy? It is because of, what is the cause? Here this is congenital disease. So the cause is genetic mutation, alteration in the gene, okay. So the cause is genetic mutation, okay. And what is the characteristic? What is the clinical feature? It is characterized by muscle weakness. All the myopathies, there is muscle weakness or muscle pathology, okay. Now here what happens? there is progressive, you can see progressive, gradually, there is degeneration of muscle fiber. But important thing to write is muscle fibers, but without involvement of nerve fiber. Nerve fiber is not involved, without involvement of nerve fiber. Okay, so this is the pathology here. Progressive degeneration of muscle fiber. You can see here, this is normal biceps. Here they get degenerated. You can see the size is reduced. Okay, now very important thing, it is of two types. One is Duchenne muscle dystrophy and second is Beeker's muscle dystrophy. We will discuss what is it. Now, this Duchenne dystrophy, muscle dystrophy, that is sex-linked recessive disorder. What is the sex-linked recessive disorder? Because the defective gene present on the X chromosome, you can see here. So, most of the time in X-linked or sex-linked recessive disorder, females are carrier. Okay. Why? Because females, they have two X chromosomes. Okay. And males are sufferer. Okay. Males are sufferer. So this is also like the same. You can see here, this is carrier mother. This is normal father. So what happens here? If suppose this X chromosome, normal X chromosome of mother and normal X chromosome of father, they will be give normal unaffected daughter. Okay. Suppose here this X chromosome of mother affected and normal X chromosome of father, that leads to birth of carrier daughter. Okay, chances are 25% here, 25% here. Then if suppose this normal X chromosome, now I will just change so it becomes easy for you to remember. Normal X chromosome of mother and Y chromosome of father, that gives birth to unaffected son. But here this affected chromosome of mother and normal Y chromosome of father results in affected son. So this is issue. Dystrophin, I will explain you. What is dystrophin? I will explain you. It is just coming. What is dystrophin? Okay, I'll explain. So now, so this is the inheritance. Okay, what is the disease here? In muscle dystrophy, what happens? There is absence of the gene. And here you can see which gene is absent. The gene for the protein dystrophin. Now what is dystrophin? Asked by Issue. I will explain you. Nice question, Issue. Good, you are attending nicely. So here I'll explain what is dystrophin. Now here we have discussed. Here you can see this is your dystrophin. We have discussed. You can see this dystrophin is attached at one end to our cytoskeleton, our actin filament. Okay, you can see here. And to the other hand, it is connected to beta dystroglycan, and beta dystroglycan to alpha dystroglycan to basal lamina. So what happens whenever there is any stretch given? This stretch is transmitted by this protein dystrophin here. Okay, so this dystrophin is important for when this dystrophin gene is absent, means dystrophin is not produced. So what happens? What is the role of dystrophin? Dystrophin is important for stability of sarcolemma. Stability of am I clear? Issue sarcolemma. Sarcolemma, that is cell membrane. Skeletal muscle cell membrane. You can see here, whatever stretch is there, it is transmitted here to the basal lamina. Okay, so sarcolemma becomes stable. So if this dystrophin is absent, this is not produced. Like suppose in diabetes, what happens? Insulin gene is absent. So insulin is not produced. Here this dystrophin is not produced. So what are the symptoms? The person, the affected child is having weakness in the muscle and pseudo hypertrophy. Hypertrophy means, I think all of you are knowing this terminologies: hypertrophy, atrophy, and hyperplasia. Hypertrophy means increase in the size of cell. Atrophy means decrease size. And hyperplasia means increase in the number of cells. Okay. So here what happens? Skeletal muscle cell size increases, but pseudo hypertrophy means they are not functioning well. Okay. So this is about Duchenne muscle dystrophy. Second is Beeker's muscle dystrophy. This is also sex-linked disorder, but the difference here is only in Duchenne dystrophy the gene is absent. So there is absence of synthesis of dystrophin. Okay. And here what happens? There is decreased quantity of, or you can see alteration of dystrophin. Okay, alteration of dystrophin. Okay, now here which are the symptoms? Some of the symptoms are common with Duchenne dystrophy. Here also there is muscle weakness, there is pseudo hypertrophy of the calf muscle, the person is having difficulty in walking, person is having myalgia means muscle pain, fatigue is there, and mental retardation is also there. Cognitive functions are lost. Okay. Now, next is myotonia. What is myotonia? Here it is the disease in which the person is having continuous contraction. Just a minute. Continuous contraction and slow relaxation. The relaxation is slow. You can see here slow relaxation. You can see muscles are contracted. Okay. After the person has stopped its voluntary activity, like suppose if I ask you to perform some action, at that time there is contraction, but afterward it must be relaxed. So here in myotonia, what happens is relaxation is absent. So continuous contraction and slow relaxation after cessation of voluntary activity. This is also congenital disease, congenital by birth. Okay. Here this is the disorder. It occurs because of absence of or abnormality of your sodium and chloride channels. Okay. And there is abnormal gene, and this abnormal gene is present on chromosome number 7, chromosome 7, 17 or 19. Okay. Now, then it is characterized by muscle stiffness. The person is having muscle stiffness, inability to relax the muscle, so muscle they become stiff. The person is having muscle cramps, abnormal contractions in the muscle. Person is having difficulty during the actions like walking. Person is having difficulty while grasping the things. Chewing also becomes difficult. Okay, so these are the causes. And genetic mutation for the channel protein, as I told you, sodium and chloride channel protein, that is absent in the sarcolemma, and because of that this all difficulties are present. Okay. Now next we have already discussed about myasthenia gravis. Now what is myasthenia gravis? As we have already discussed, it is neuromuscular disease in which the person is having autoantibodies. Antibodies are produced against acetylcholine gated channels, acetylcholine gated channels. Okay, antibodies are produced and they destroy acetylcholine receptors. You can see here. So the person is having difficulty in muscle contraction. and sometimes it may lead to death of the individual because of involvement of respiratory muscles. Issue, congenital. Okay, meaning of congenital means by birth. Congenital means congenital, that is by birth. By birth. Okay. Acquired means produced after birth. Okay. Acquired means after birth. Okay. So this is about myasthenia gravis. Okay. Next is Lambert-Eaton syndrome. Issue, is it clear? Next is Lambert-Eaton syndrome. This is also neuromuscular disease. Clinical features are same as myasthenia gravis. The person is having muscle weakness. Okay. But pathology is different. What is the pathology here? You can see antibodies are produced against here calcium channels. So there is no entry of calcium, and if there is no entry of calcium, this acetylcholine vesicles cannot be broken down and acetylcholine cannot be released. So the drugs are different. In Lambert-Eaton syndrome, drugs are different, and in myasthenia gravis, they are different. Okay. Next is disease involving muscle tone. They are either increase in the tone or decrease in the tone. So one, that is hypotonia, decrease muscle tone. That results in flaccid paralysis, loss of tone and loss of firmness. Normal muscles are firm, but here firmness of muscle is lost. Firmness of muscle is lost. Okay. Cause is, commonly this hypotonia is present in lower motor neuronal lesion. We have discussed what is lower and what is upper motor neuron. As all of you are knowing, suppose this is your spinal cord. Good. Issue, good. You remember congenital. Suppose this is your spinal cord. Okay. Here. Okay. So the neuron which starts from this ventral horn and it supplies muscle, this is your lower motor neuron. Okay, when lesion is here, that results in hypotonia. Okay, and hypertonia, increase in the muscle tone, and here muscle cannot be stretched. The cause is here, the cause is upper motor neuron lesion. Now what is upper motor neuron? Neuron that starts from the CNS here and which controls this lower one. Okay, so cranial and spinal neurons, these are upper motor neurons. So upper motor neurons, when there is lesion here, then the tone increases. Why? Because this upper motor neurons, they control lower one. So when these upper motor neurons are damaged, then there is hypertonia. Okay, here there is either spasticity or not. Okay, so you can see stiffness in the limb, muscle tone increases. In hypertonia, difficulty in moving and muscle spasm is there. Whereas in hypotonia, there is floppy limb, flabby muscle tone decreases, difficulty in standing and lack of stability. If you want to get the idea about hypotonia, you just look at the person's limb with poliomyelitis. Okay, so that is decreased tone. Okay, cannot stand without support. Next is fibrillation and denervation hypersensitivity. What is this? When there is denervation, you can see this is skeletal muscle which is supplied by the nerve, and when this nerve is to be cut, what happens? There is, you can see, because of denervation, there is, you find fibrillation and denervation hypersensitivity. Fibrillation means there is, you can see there are fine, irregular contraction of individual muscle fiber, of individual muscle fiber. Okay, fine irregular contraction of individual muscle fiber. And there is also denervation hypersensitivity, means after denervation you can see large amount of acetylcholine is here. So whenever slight stimulus is given, then there is increased response. This is denervation hypersensitivity. Okay. Then last one, that is Macarthurs disease. What is this? This is also known as glycogen storage disease. Here what happens, glycogen is stored. Normally what happens, in our muscle we have glycogen. Okay. And whenever we are performing any activity, this glycogen is converted into glucose. Okay, normally. But here what happens, for this conversion of glycogen to glucose, we require glycogen phosphorylase enzyme. Okay, glycogen phosphorylase, and gene for this enzyme is absent. So what happens, glycogen is there, we have glycogen, but it is not converted into glucose. So there is deficiency of glucose. You can see here, this is normal skeletal muscle contraction. You can see here, whenever muscle contracts, ATPs are required. How these ATPs are produced? By glycolysis. Glucose, and all of you are knowing Krebs cycle and all. Okay. So during this Krebs cycle, what happens, from one glucose molecule, 38 ATPs are generated by the aerobic glycolysis of one glucose molecule. But here what happens, because this glycogen is not converted into glucose, you can see glycogen is not metabolized, so there is lack of ATP. Okay. So what happens when there is lack of ATP? Then the person is having muscle pain while performing muscle contraction. Person is having fatigue, okay, muscle failure, muscle stiffness. So this all are the clinical features in Macarthurs disease. This is known as glycogen storage disease. Okay. So this is all about today's topic. We have discussed some diseases today, and these are the questions from today's topic. All the answers of these questions I will discuss in my special class. My special class is scheduled on Saturday, that is today is 19, 20, 21, 22, 22nd January 22 at 3 p.m. Okay, and Sunday 23rd January 22 at 2 p.m. Okay, so on both of these dates we will discuss all these question answers. Okay, just write down questions if you wish to write down one, that is what is electromyography and electromyograph. Write down EMG finding at rest, what is insertion activity, what is end plate noise, what are EEG changes during voluntary activity, what are the fasciculation potentials and fibrillation potentials. Write down about muscular dystrophy and types of muscular dystrophy. Okay. 6th question, write down pathophysiology and clinical features of Duchenne muscle dystrophy, pathophysiology clinical features of Bickus muscle dystrophy, pathophysiology clinical features of Myotonia, fibrillation and denervation hypersensitivity, and pathophysiology and clinical features of Macarthurs disease. Okay, so these are all the questions from today's topic. Okay, so this is all about today's topic. Here we are completing skeletal muscle. Okay, tomorrow is a strategy session, and day after tomorrow we'll be having our session in which we will start smooth muscle. Okay, so we will discuss smooth and cardiac muscle. Okay, they are left, that we will discuss after this. So we have completed the topic of skeletal muscle here. Okay, if you have any doubt, you can put your doubts in the comment box. We'll try to resolve all the doubts. I'll try to give answers in that comment box, please. Okay, so here I'm ending my today's session. Thank you. If you like my video, you can like it, you can share with all your friends, all your NEET UG aspirants, those who are planning to get admission in medical field. Please share videos of our channel, because they are going to be very useful for all of them. Okay, share with them and subscribe our channel Unacademy.